Hey everybody, so we're just logging on and we're going to give people a couple of minutes to get logged on and then we'll get started. And Rick's going to go ahead and pull up his PowerPoint. So Rick, we can see your screen
Yep.
right now. There we
Trying
go.
to share the proper screen to see if I do it this time.
So while everybody's getting logged on, and I'll re-go over this, but just to introduce myself, my name is Brooke McGivern. I just had a name change and I'm the Director of Marketing and Communications here at Tim's Medical. So I'm just here to help monitor and answer any technical questions. But for those who are participating this evening for ASHA CEUs, a couple of quick housekeeping things. We do ask that you're present for the entirety of this webinar. It's an hour and a half, so you'll get 0.15 ASHA CEUs or PDHs. And then to get those, you will need to fill out the survey. So the survey link will be emailed to you about 2 hours after this presentation concludes, but you can always access it on our website and I'll pop it into the chat too, so you can fill it out at any time during this presentation. And if you wish to have a certificate of completion sent to you, just send me an email at tims-univ@tims.com and I will put that in the chat, but you can find it on our website too. And we do just ask that you send us an email because we don't automatically send those out. So with that, I'm going to pass it off to Rick and he is going to kick us off. Rick.
Thank you so much, Brooke, for coordinating this. I love all of the new platforms that we have access to learn. And I'm loving tonight's meeting because I still learn a lot from Dr. Dumican. There's a lot of things in my 32 years that, I did a lot of subjective analysis. And so the amount of depth we can do, we're excited to share everything that we've been learning and doing from our company as AmpCare. Thought I didn't get the disclosures. You have those out there though. Russ and I are both employees of AmpCare. We get paid sometimes and we travel and manage the company. And Dr. Dumican doesn't have any financial or non-financial disclosures. So I was going to tell just a quick story about how AmpCare came about, because I think it sets up the premise behind all of what you're going to learn tonight. My career in speech language pathology started in 1991. And it wasn't too long after that I met Russ Campbell. And outside of a few pitchers of beer at a local watering hole near our hospital, before we were married, before we had kids, we certainly learned probably a little bit more about each other. But the Joint Commission came in, and the buzzword at that time around 92, 93 was interdisciplinary care. So that forced me in my 2 years of clinical practice. I was fairly efficient. I felt like in modified barium swallow studies, I had that credential, if you will, at the hospital. And now I had to go in and demonstrate some of the swallowing therapy techniques that I'd been taught. Obviously, significant amount of compensatory strategies, and then some very subjective therapeutic activities such as thermal stim, oral motor exercises. And then Russ had one of our patients we were both seeing, a stroke patient, Mr. Hubbard, I believe, came up in a standing frame. And I'd never seen him stand. And Russ had electrodes all over the leg. He was working on weight bearing. Every time the stimulation would come on, the contractions would happen. Patient would work on weight bearing and activities for that muscle re-education or muscle rehab. And then you had me. So I looked at that kind of like the Jetsons, and I came in as like the Flintstones. I had my cup of ice. I had my laryngeal mirror that I thought was really cool because I could get them from surgery and get them sterilized. I had my tongue depressor. So I had like elements of the earth. I had wood, some ice. And so, the patient's looking at me and also looking at Russ, like there was a significant gap in muscle rehabilitation happening within this patient. And I would have to argue that every patient I've seen since then is certainly that patients Russ and I were both treating, the swallowing was extremely important to that. So it was kind of interesting to see his look when he saw what I was going to do for swallowing and when I saw what Russ was doing for muscle rehabilitation. So that's what led to Russ and I starting to, I guess, discern how could this modality, and again, if this was early 90s, I think we wrote our first white paper, which is on our website back in 98. So it took us a few years. And I remember Russ asking me, what would you want to stimulate? What is it you want to do? If I were to help you with this modality for your patients. He didn't know anything about swallowing. And to be honest, from an anatomy standpoint, that's a little bit of what I wanted to cover to just to kind of show where we were thinking, what we were thinking about. I think as a clinician at that time, for me, I was highly compensatory. I wanted something that would take care of this problem. And Russ was coming from a mindset of rehabilitation, rehab, good old fashioned rehab, challenge the patient and change the patient. So that led to what we now know as AMP Care, which was company founded in 07 and launched our products back in 2014. So we're in our 10th year, significant amount of information, but that is the ESP kit, which the electrodes, the stimulator, and the posture device are all involved in that ESP, or the effective swallowing protocol. So when Russ asked me, what is you think you want to do with this simulator? I can get some electrodes, we can get some parameters, we can start looking at some of the science behind small muscle groups. And in full honest disclosure, it was a memory test for me. I didn't have that at the back of my mind. Oh, I want to improve hyolaryngeal elevation. That was one of Barbersoni's and some of the previous thought leaders in our industry, that hyolaryngeal complex, if it's not moving properly, you have a higher risk of getting that penetration, aspiration, or airway invasion. So looking at Gray's Anatomy, okay, what would we want to do to help facilitate the hyolaryngeal complex? Now, using electrical stimulation, which we go very much in depth on in our training, where you're putting your electrodes facilitates what movement is going to occur. That's also going to be what is strengthened. That's also going to help with the afferent sensory pathway to help facilitate the efferent or motor response that the patient may not have at that time, but you're trying to remodel that cortex and work towards that philosophy of neuroplasticity. So looking at the Gray's Anatomy, the anterior digastric and the mylohyoid were perfectly situated. They were superficial. They were just underneath the platysma, which you can't bypass. You have to go through all of them. And they were superficial enough to where we could, if we depolarize that trigeminal nerve to help that anterior digastric mylohyoid contract, we can facilitate the hyoid to move forward and upward. And we'll demonstrate that at length tonight. But I think that facilitates an exercise that we're all trying to teach, or could work, being the Mendelssohn. If you can swallow and hold that elevated status, that creates an effortful swallow, you get more of a functional response. Now, it's hard for patients to understand it, but when you start looking at the kinematics that are associated with that anatomy, it facilitates that hyolaryngeal complex forward and upward. And so it starts working that afferent through the brainstem to the cortex, efferent with that patient attempting to swallow in response. And this is kind of a cadaver view, that submental triangle. And directly underneath the chin, you've got that anterior digastric mylohyoid, and that leads to what you're about to see is that electrode placement. So it's not a focused guess. It's not throwing darts. I think it's kind of like Russ would say, we want to cover and bombard all of those motor points within that area of treatment. So if we can facilitate depolarizing the trigeminal nerve to get that anterior digastric mylohyoid to contract, you're going to get two things, either mandibular depression or hyoid elevation. And when we can work with that patient to maintain their jaw closure, help that patient to facilitate that forward upper movement of the hyoid, it's going to facilitate that motion. It's very difficult to train a patient to do that. You can ask a patient to do an effortful swallow. But as I talked about facilitating the proper movement, which I think is important, the other dynamic aspect of this exercise is it stretches open the laryngeal vestibule. So now not only are we facilitating an exercise, but we're creating an intrinsic stretch that makes it perturbation. It makes it challenging. It makes it resistive. So when you can facilitate a movement and also create challenge, create that resistance, that helps that patient work to overcome that, which will in turn hopefully facilitate that neuroplastic effect of the exercise. And that's what we've been seeing in the data. And what we'd like to show tonight, and Dr. Dumican will end with some fascinating things that we can now see, as opposed to just a change in a swallow study. Now we're going to get more kinematic changes. So the first FDA cleared powered muscle stimulator was AmpCare. It had multiple adjustable parameters. And these follow those rules of Russ's, his training in electrotherapy. You need to manage those treatment parameters for comfort and also for functionality. Just to put a stimulator on a particular muscle group and hope that the box in itself does what it says it's going to do, and he will show you, there's a ton of ways to use electrical current. And when you facilitate them to the science supported parameters, you can do so comfortably and you can get a very significant amount of movement. And so as you remember the anatomy in that submental region, that anterior digastric mylohyoid, these electrodes are perfectly situated at that prominence of the thyroid cartilage and up, where we're bombarding all of the motor points, and they are a large pie-shaped electrode to disperse the current evenly. There's not just a lead wire into an electrode pad. We fan out the lead wires so the current is driven into the whole entire pad, and that makes it more comfortable. They are reusable up to 5 visits, and then you dispose of them, but they are single patient use. And we use a submental and a facial placement, and it can very well functionally support both of those, and we have a youth and an adult size. Class 2 medical devices are not sterile, but they are FDA cleared class 2 devices. And this is a demonstration of, I think, the important part of this technique. To use a term neuromuscular electrical stim, I think that's movement is supported by that. Otherwise, I think you're doing more of a TENS or a sensory level approach. So in order to get that motor contraction, you may need, and the science would support, a higher level of intensity using a shorter phase duration. And that's way in deep in the electrophysiology, but that's what science would support. And using a higher level of intensity with the shorter phase duration will make for a more comfortable contraction. And you pair on top of that the amount of current that's distributed in this slide, the low yellow and green. This is, by the way, 100 milliamps of current going through this electrode, which would be the AmpCare design. And this is your standard round 0.8 inch, the standard electrodes that are used as well in our industry. And if that hot spot, when you have that lead going straight into the pad, that will have and lead to more of a risk of a hot spot of that electrode pad. And when you have that hot spot, that may make the patient turn it down. And when they're turning the intensity down, you're maybe going into that sensory approach as opposed to motor. So we took great care to make sure that we're following through that comfort. Now, the last component, I mentioned that these are mandibular depressors or hyolaryngeal elevators, or at least part of that hyolaryngeal complex. We can also utilize a posture device, that's the P in the ESP, and that will help facilitate jaw closure. It will also facilitate some extrinsic neck musculature exercises, resistance, chin to chest exercises, if you will. We've had that evaluated with surface EMG, and we can double the amount of nerve conduction from the Shakir exercise with laying the body flat and using head lift to gravities. We can now do not gravities, one gravity, and then you can sit in a chair and you can do the exact same thing into this brace. And this brace is it's a Kydex. It's very well known in the PTOT world. It will push back. It's like a fishing pole. You don't just push in and consider that resistive. When you push in, it's going to start pushing you back as you start to fatigue a little bit. So it helps in that posture. And a lot of patients that we see now, we don't have to put the lead glove on and hold the head up and evaluate them in a manner that they're not going to go back to the facility and maintain. So whether it be fees or modified, we can get them in a proper upper head position and maintain that level, not only throughout the examination and assessment, but also to turn that back over to those patients when they get into the facility. So that's just a very brief 30,000 foot look at the materials, I guess, that we use, our equipment, our ESP kit. Now what we do with that's what I'm going to let Russ demonstrate and show through some video, which I think is fascinating, from modified barium swallow studies and fluoroscopy fees. And you're going to see some of the kinematics, because I think the important part that I want everyone to take away is that NMES is not magic. It doesn't find its way to all of these intrinsic parts. And so because of that, I think it's very important to understand the anterior aspect of the anatomy and what's most superficial, and what we can create as far as kinematics. And by that, I mean that anatomical chain. And by moving some structures within NMES, we are facilitating others. And I think you'll get a very good understanding of that from Russ's perspective. And Russ, I see you've taken over, so I think you're spot on, right where I needed to be.
All right, Rick. Yeah, thank you all. And Brooke, appreciate you all. As Rick and Brooke said, my name is Russ Campbell, and I am a physical therapist by trade, but I've been working with Rick McAdoo and Rhonda Polanski for almost 30 years, y'all. And we've been utilizing and developing this technology known as the effective swallowing protocol, or what we call ESP. So I think Rick is spot on. I think it's not just about the patient's swallow study improving. I know that's all the patient cares about, but for data and research, you need to be more objective, and we need to be able to validate movements. And in my profession, we have a goniometer. It's a measuring device that measures range of motion in any joint. So we can assess the elbow at 0 degrees extension or 90 degrees of flexion up to 120. So we have some objective ways to do this. And I think what this technology has done, what TIMS Medical has done with the advancement of this technology to this TIMS MVP system, is allow you to validate what you saw in your pre-treatment swallow study to what's happening in your post. And I think that's what's needed. I think just saying that NMES works is not enough. We have to be able to prove it. And the way you prove it is to show people what impairments you can address with this modality. And you just want to think of a modality as a form of treatment that we use to help a patient overcome these impairments, right? So that's what we're going to do. I'm going to show you some targeted impairments that we can address. I'm going to focus on 2 and talk about the other 10 that we can also do, but for our time's sake, we'll focus on 2 impairments that I know we can address directly. And then after I'm done showing you how we do that, we'll later let Dr. Dumican show you how he utilizes this TIMS MVP system to validate it, to prove what we do. All right. So the process by which neuromuscular electrical stim works has been well documented in my field. And these 2 impairments that we're going to talk about today has been well documented in the data that we have published on our website. You can download this for free to go to the website at ampcarellc.com. You can get a summary of all the evidence and then click on the full peer-reviewed article, poster presentation, or oral presentation that's there. So take a look at that if you need more proof. But the extrinsic muscles of the swallowing mechanism bear no real histological differences than the muscles that I would treat in an arm or a leg. Basically, there's type 1, type 2 muscle fibers. There's actin, there's myosin, there's mitochondria, there's myoglobin, okay? So these muscles that I'm treating in my arms and legs, although they are bigger than these suprahyoids that Rick is alluded to, they still are composed or made up of the same muscle proteins, this actin, myosin, type 1 and type 2. So if NMES works in physical and occupational therapy, it will work in speech and language pathology. You just need the right parameters, the right electrode placement, and then we have to also incorporate posture. So what I really think we want to focus on is understanding what impairments we think we can address. And Rick already alluded to it. We can directly stimulate these suprahyoids, the anterior digastric, the mylohyoid, and geniohyoid, and move the hyolaryngeal complex in a forward upward direction, so similar to a Mendelssohn maneuver. Whether a patient can comprehend how to do a Mendelssohn or not, we're going to be able to facilitate that range of motion. And then I'm going to show you in some still shots and some videos how we actually can stretch open the laryngopharynx, stretch open this laryngeal vestibule, which may sound counterintuitive to the medical SLP. Why are you stretching it open? We're stretching it open so that when you trigger that patient to swallow, they have to overcome that stretch open. And that will speed up laryngeal vestibule closure times, or the time for that airway to close. So those are the two impairments we're going to talk about. But as this presentation is named, the differences in electrical stimulation, I have to stress that parameters matter, y'all. Parameters are like the ingredients to cooking. If you're not using your favorite, your favorite recipe and putting in the right ingredients, you're not going to get the same taste, the same texture, the same outcome. So we'll talk a little bit about electrical stimulation parameters and how we differ, and then the importance of electrode placement. If your main impairment is hyolaryngeal excursion, there is no rationale to strengthen the infrahyoids, in my opinion. So understanding the electrode placement, parameters, and impairment, it's vital to how we use this modality in NMES and how we show its effectiveness, okay? So let's move on. I think everyone here would be okay with me saying if I pick two impairments that you would typically see in a pharyngeal dysphagia, one might be reduced or delayed hyolaryngeal excursion, and then the other one might be an ineffective or inefficient laryngeal vestibule closure, the inability for that laryngeal vestibule to close. And the beauty of this software, this TIMS MVP software, is now we can measure temporal time measurements. We can measure the speed of airway closure, and we can also do spatial measurements. So we can measure the distance of hyolaryngeal excursion pre-treatment and then post-treatment to see if there was any differences, and we addressed these impairments. So basically, we've been utilizing this system as our goniometer, as our eyes, to tell us, have we improved hyolaryngeal excursion and have we sped up airway closure? All right. So again, this would be just some pictures to prove that when you have absent hyolaryngeal excursion and you offer a bolus, you will get retention in the vallecula, the piriform sinus, and even some penetration leading to aspiration. All right. So when I asked Rick, how do you want to use NMES? He said, man, if we could address this, this would be a big deal. And I said, no problem. It's very easy to get to. These suprahyoid muscles are right underneath the platysma. They're not very deep. I'm going to prove to you that we can get to the anterior digastric, to the mylohyoid and the geniohyoid with this current and this technology. And then you can see to the right how you have a more patent, non-obstructive path for the bolus to go. You have hyolaryngeal excursion. The hyoid has approximated or come closer to the mandible, allowing that bolus to go from high pressure to low. So that shows one of the impairments we're going to address. And I think the other impairment, everyone would agree, is some form of incomplete or delayed laryngeal vestibule closure. And I'll let Dr. Dumican get into how they describe this and measure it. But when this hyoid bursts forward and upward and it continues to go, that's the beginning of closure of this laryngeal vestibule. And when your arytenoids hit your epiglottis, that's complete closure. He'll go into that. But you can see here on the far left that we have bolus entering this pharyngeal area. We have it going by an open airway, incomplete closure, and we have the hyoid bursting. So this can lead to some trouble, right? And if we can address these two impairments, I think we're going in the right direction to addressing a lot of the pharyngeal problems that we see with the pharyngeal dysphagia. And on the far right, you can see that the arytenoids have come up and completely hit the epiglottis, sealing off the airway, allowing a patented pass for the bolus to go through the pharynx into the esophagus. So why is the range of motion to the hyoid so important? I've heard thought leaders say the hyoid's overrated. And it may be, but not when it comes to NMES, y'all. Not when it comes to this technology, because your hyoid is attached to everything. So if we can move a hyoid, if we can move it in the correct direction, it's going to move every structure with it. That's kinematics, the motion of an object. What happens when you move one object? What does it do to other things? So let's talk about it. So when we get your hyoid to move forward and upward, similar to that of a Mendelssohn maneuver, your tongue sits atop of your hyoid in your oral cavity, right? And the tongue actually touches the hyoid via a muscle called your hyoglossus, attaches your hyoid to your tongue. So as we move the hyoid forward and upward, the tongue base has got to come with it. And that's based on anatomical inference. It's based on kinematics. Because the tongue is attached to the hyoid and we move the hyoid, there's going to be some motion, a domino effect, that the tongue base is going to move with you. Now, the next thing that's going to happen is your hyoid attaches to your larynx via a thyrohyoid ligament and a thyrohyoid membrane. A ligament is like a rope. A membrane is like a sheath. So as the hyoid moves, that larynx is going with it, y'all. So here we go. Hyoid moves, the larynx is coming with it. All right, because it's attached by a rope, basically. All right, and the beauty of the hyoid and the larynx is that they both attach to your epiglottis. All right, you have a hyoepiglottic ligament and a thyroepiglottic ligament. All right, these ligaments, again, they're like ropes. Your epiglottis is a cartilage. All right, it's not supposed to respond to electrical current, but because we move the hyoid, and there's a ligament that attaches to the epiglottis, and that when the hyoid moves, the larynx is coming with it. And there's a ligament that attaches the larynx to the base of the epiglottis, right? So as the hyolaryngeal complex goes up and it grabs the base of the epiglottis, it actually inverts it, retroverts it, makes it fall backwards, shallowing the vallecula. And if that's not making sense, just picture Brooke standing on this table right here. Brooke standing on my table. If I grab Brooke's ankles,
She's pregnant. She can't fall down. Don't pull her upside down.
Wait. Has she not had this baby yet?
No, that's why we're doing this.
Oh no. Well, then we won't use Brooke.
Just pull Matt.
All right. So we grab Matt's legs, feet, ankles, pull them forward and upward. If I yank Matt's feet forward and upward, Dr. Dumican's going timber, baby. He's falling back. And that's going to shallow the vallecula, right? All right. So what else happens? As we're pulling this hyolaryngeal complex, your middle pharyngeal constrictor, y'all, you remember these muscles behind the back of your throat? Your superior, middle, and inferior pharyngeal constrictor. Their job is to milk that bolus down the back of your throat. Your middle pharyngeal constrictor attaches to the corneas of the hyoid, so it sets up beautifully. So when the hyoid moves forward and upward, you're actually middle pharyngeal constrictor. It's not doing anything. It's anchoring. It's holding back. And you actually stretch open this laryngeal pharynx and shallow the piriforms, right? Because if the middle pharyngeal constrictor is staying here and you're pulling that hyoid forward and upward, you can see how the laryngeal pharynx stretches or gaps, and that's going to also shallow the piriform sinuses, all right? And then science supports, y'all, when the hyolaryngeal complex goes forward and upward, you will inhibit the PSUES. Yokoyama said it in 2000 and I want to say maybe 2010, Japanese thought leader, shows that when the hyolaryngeal complex goes forward and upward, you will inhibit that PSUES. So these 6 things with one placement, y'all, you don't need 6, one placement under the chin, facilitating hyolaryngeal excursion can do all of this kinematics. We call it anatomical inference. It's a domino effect. It's a chain reaction. If Dr. Dumican was tied to Brooke with a rope, which was tied to Rick with the rope, and I pull that rope, they're all coming with me. It's a chain reaction, a domino effect. That's what a ligament would do. But there's some muscles in here too. We talked about the middle pharyngeal constrictor. We talked about the hyoglossus. It's more elastic. It's more like a rubber band. But if they were all tied together with a rubber band, y'all, and I pulled that rubber band, the person who is first attached to that rubber band, Dr. Dumican, would move the most. Brooke would move the second most, and Rick would still move, but he's not going to move as much because he's third in the chain. But because the rubber band's elastic and it'll stretch. So take that for what it's worth. Now let me prove it to you. All right. So we talked about impairments. Let's get into parameters. As I said, parameters are like the ingredients to cooking, y'all. And if you're not using the right parameters, you're just not going to get the right effect. And most of you know, one of the biggest problems with electrical stim in the form of neuromuscular electrical stim is that it can get painful, right? So let me explain this. In electrotherapy, you have 3 different types of currents: alternating, pulsed, and direct. You have 10 different waveforms: interferential, pre-mod, Russian, high volt, neuromuscular electrical stim, TENS, and iontophoresis. I'm going to tell you that AmpCare's effective swallowing protocol is a subset of this neuromuscular electrical stimulation symmetrical biphasic waveform. This is where we lie. And I'm going to tell you where most of the technology that came out in 2001 lies more under a sensory stim approach, okay? And then these things: frequency, phase duration, output or intensity. Think of these as ingredients. Think of these as sugar, salt, flour, cayenne pepper, whatever you're putting together in your recipe. That's what it is. And look, I'm a big pound cake fan, and my favorite pound cake was in Atlanta, Georgia. When I asked the lady that made this pound cake, I said, how many cups of sugar did she use? And she said 6. I said, woo, well, that's all the sugar for my content for the month. But I asked her, what happens if you only use 1 cup of sugar? And she said, honey, it would taste like, and I'll let you fill in the blank. All right. So, and it was a drawn out 1-syllable word that she drew out for a few minutes. So you all figure that out. So let's get into these parameters just a minute. And I'm a dad, so I got to start off with frequency, because I like to tell a dad joke. What happens when someone hits you with high frequency? It hurts. All right. Maybe I see Dr. Dumican not laughing too much. He's just grinning.
I've heard it too
so
many
maybe
times.
It doesn't matter. So look, AmpCare uses a very low frequency, because high frequency, when you hit someone with it, it hurts. And hertz is a unit of measure. Not only does it physically hurt, but it's also called a unit of measure. So hopefully that makes sense why we told that joke. We couldn't be more different than a vital stim or e-swallow. We use a low frequency with a low phase duration and a high intensity, 100 milliamps. And for those of you that use this other technology, you'll know you can't get over 25 milliamps, because when you do, it hurts. And it all goes back to the frequency and this high phase duration. We spend an hour in our training explaining what this all is, and I'm not going to get into it today, but I'm here to tell you that our parameters couldn't be more different than a vital stim and e-swallow. And I would tell you, we are not the exact opposite because we wanted to be different. Science supports a low phase duration and a low frequency with a high intensity on this rich and diverse sensory system as your neck and your face. Science supports this for small muscle groups. It's called the strength duration curve. Come to the training, we'll spend a long time teaching you about that. But here's the other thing you need to know. The duty cycle. How long is the stimulation on for and off for? We're only on for 5 seconds, y'all, because we want to elicit a sensory afferent pathway to the brain and an efferent motor. And you cannot sustain an electrically induced muscle contraction for much greater than 5 seconds. You can do it, but when you do it, it hurts, y'all. And that's why I'm telling you, when you're using a technology that's on for 59 seconds, you may be able to elicit motor, but you cannot sustain it. You cannot sustain an electrically induced muscle contraction for 59 seconds, relax for 1 second, and then do it again for 60 minutes. So what the patient ends up telling you with this is it's sensory stim. What we're going to show you is how true sensory motor stimulation can create this hyolaryngeal excursion. All right? Beautiful. So this is what ESP does. And I thought showing you a side-by-side contraction of what we're doing so you can see the motor under fluoro, but also what it looks like on a patient. Because I know other technologies say they can do this, but they can't prove it. And I'm about ready to show it to you under fluoro, fees, and ultrasound. Okay, so what are we doing? We are electrically stimulating nerves. We're going through the facial nerve because the platysma is the most superficial muscle and it's innervated by facial. And then we got to go through that platysma into the suprahyoids, anterior digastric, mylohyoid, both innervated by trigeminal nerve. And then the geniohyoid's a little deeper, and that's innervated by C1 of a branch off your hypoglossal nerve. So we're stimulating nerves, causing muscles to contract, recruiting more muscle fibers than you or that patient can do on their own for therapeutic benefit. So whether this patient can comprehend how to do a Mendelssohn or not, we're going to be able to pull this hyolaryngeal complex in a forward upward direction. You're going to see the motor on the far left. That's true NMES. It's on for 5 seconds. And then you can see how the hyoid's moving on the right, forward and upward for 5, and then comes back to a resting position. Okay, so this is what we do. And I guarantee you, you get beyond 5 seconds of this, 8 seconds, that's a typical isometric contraction. What's isometric? Moving a muscle, making it contract, but not creating a lot of joint range of motion, just getting the muscles to fire. All right. And I want to make sure everyone understands we will always pair this with a swallow. It is the most specific exercise for someone with a swallowing disorder. And why? Because we are jump-starting it. We're getting the hyolaryngeal complex to go in the right direction. We are facilitating it by stimulating this trigeminal and C1 hypoglossal nerves here, getting this hyoid to go in the right direction. All right? And at the same time, everything I said about anatomical inference is occurring. Look at what's happening. I'm going to freeze this now. My tongue base has got to come with the hyoid because it attaches via the hyoglossus. My larynx has to move with the hyoid because it attaches to the hyoid via a thyrohyoid ligament and a thyrohyoid membrane. I told you the hyoid and this larynx attach to your epiglottis. So as the hyoid and larynx move up, the epiglottis starts to retrovert, shallowing this vallecula here. I also said your middle pharyngeal constrictor comes around and attaches to the cornues of this hyoid. You can see the gapping here. This is the stretching open of this laryngopharynx, the stretching and shallowing of the vallecula, okay? Not just the vallecula, excuse me, the piriform sinus. Piriform sinuses are down here, those little pools right next to the PSUES. They're being stretched forward, shallowing the piriform sinuses. Your vallecula gets shallowed because the hyolaryngeal complex goes up. It tugs on the bottom of this epiglottis, this cartilage, retroverting it, shallowing it here. So you can see how these type of kinematics combined with effortful swallowing will address hyolaryngeal excursion. And when they swallow against this resistance, their airway being pulled open, swallowing to close it, and they do that repetitively, 60 to 72, up to 90 times. We're going to get them to do that in 30 minutes. That's going to speed up airway closure times, okay? So now, I'm going to show you a few videos under fluoro, fees, and then ultrasound. So here we go. Everyone should see the patient here at rest. Patient's not asked to do anything. Stimulation's on. You should see the muscle contracting here. The muscle gets shorter. And as the muscle gets shorter, you're going to see the hyolaryngeal complex go up. 5 seconds, and then it just fell down, okay? So here we go. Stim's off. Then stim comes on. 2, 3, 4, 5 seconds, and then it falls back down. So this just shows you the power of the NMES. Using the right parameters, the right electrode placement, you can elicit hyolaryngeal excursion, okay? I just froze the video here because I wanted to show you that we're getting a pseudo Mendelssohn. What I mean by a pseudo Mendelssohn, we're facilitating the range of motion of the hyolaryngeal complex. So here it comes again. Stim is on. Hyolaryngeal complex goes up, holds it for 5 seconds, and then comes down. So this is the video we showed the FDA how we're different, how we are improving hyolaryngeal excursion, facilitating it while creating a resistance here. And you can see this patient is starting to feel this little stretch reflex going on. They're not used to someone just grabbing their hyoid, pulling it forward and upward. And you can see that they're trying to fight back a little bit. It's called a stretch reflex. If I walked up to Brooke and Brooke didn't know I was behind her, and she had it could be a sweater, a purse hanging from her wrist. And I walked up behind her and I grabbed her wrist to pull it down, to take that sweater or that purse out of her hand. What do you think Brooke's protective reaction would be? Fight back. Not that I'm saying she looks pretty mean, but if she's not smiling, she might turn around and pop me one right in the face, right? So that's what's happening here. They're fighting back. Now look, they relax, the airway's open. All of a sudden the patient goes to swallow. When they swallow, what happens? Hyoid goes up, airway shuts, and now you've created the best resistive exercise you could ever do for a patient with a swallowing disorder. Amp care is nothing about being a compensatory strategy. We're not going to feed people with this on. This is good old-fashioned exercise. All right? When we go to motor, we are creating a much more effective, effortful swallowing exercise. We are creating a perturbation. What's a perturbation? It's a disruption to a movement goal. When you swallow, your airway should close. What are we using with amp care? We're pulling it open, perturbating it, changing the body's way to react, causing their central nervous system to overcome that change. And when you do that repetitively over time, you will speed up airway closure, okay? So that's it under fluoro. Let me go ahead and show you this under fees. There we go, right? So I'm assuming everyone's comfortable with fees, but let me give you a little orientation from anatomy. So obviously we got a fiber optic tube coming up through the nose, going down into that oral pharynx. This is the back of the throat, the pharynx. This is your epiglottis. Back here is your airway, right? In the front of the epiglottis is your vallecula. Here is your tongue base. What did we say? Tongue's attached to the hyoid. So when we get hyolaryngeal excursion, what should happen? That tongue's going to bow. That airway's going to get stretched open. The epiglottis is going to start to retrovert, right? So watch it again. Look at how that tongue bows. Patient's doing nothing, just getting AmpCare's effective swallowing protocol to prove that this kinematic effect, this anatomical inference, can have an effect all the way down to your PES, UES, y'all. So let me explain it to you again. I froze the video. Look at the tongue base. Does everyone see how that thing is bowed up? That's bowing because the hyoid's being pulled forward and that is pulling the tongue base with it, all right? Everyone should see how the airway is being pulled open. This is why we're a little different than other technologies. When you go to motor with AmpCare, you're not feeding them with this on. We don't want to compromise them with this. This is an exercise. Just get them to swallow, right? So the epiglottis have been pulled up under the tongue and is inverting or retroverting, shallowing the vallecula. What is this right behind this arytenoid? This is your PES, UES opening. I told you that when the hyoid moves, a kinematic effect, like a domino effect, is going to cause the hyoid to move, the tongue base to move, the larynx to move, the epiglottis to move, the posterior pharyngeal wall to be stretching open the laryngeal pharynx, shallowing the piriforms, relaxing the PES, UES. And that's the beginning of it. And this is all with the NMES, y'all. So this is why it's exciting to me. We're showing you these impairments we can address. with one placement, one set of parameters, electrodes under the chin, and then just get them to swallow. And we'll teach you how to trigger swallowing on patients who might have difficulty, pleasantly confused, have some dementia, right? How to use cold, wet spoons, things that are autonomic to trigger swallows during the stimulation on time. So hopefully that makes sense to what we're doing, all right? And then I'll just show you one last video here. I think this is worthwhile to show. Some of us may not be comfortable with ultrasound, but this is from our colleagues in Japan. So we've been working in Japan for about 6-7 years now. So one of the Japanese thought leaders thought he wanted to know how deep the current went. And initially I was like, yeah, it's irrelevant. It doesn't matter to me. I got the hyolaryngeal complex to move, but it's always relevant. There's always something you can learn from someone. So let me show you this. Know that this is where your anterior belly of the digastric is. Because it's really thin, you don't see much of it. The thicker muscle, the mylohyoid, is here. You can see how it's a little darker. And there's your geniohyoid right here. It's a little darker. So you'll see what happens when we turn the stimulation on. You'll see how that muscle just contracted, just got shorter. Yeah, I see a couple eyelids popped up. That's good news, people. Yeah, a couple gunshots, you betcha. Thank you. So why is this important? Look at this again. That's at rest, right? Watch what happens when stim comes on. That's contraction right there. And now relaxation. Why is that so important to me? Because we're not just getting the trigeminal nerve. Trigeminal nerve only goes to anterior digastric and mylohyoid. Geniohyoid is C1 and a branch of your hypoglossal. So now we know current's going deep enough to get to that geniohyoid, and the patient hasn't done anything. And we're stimulating more muscle fibers than you or that patient can do on their own for therapeutic benefit. It's better than any other exercise. When you exercise traditionally, you got to wear out your type 1s before you get to that muscle burn. And then when you get to the muscle burn, you're starting to get to those 2As and 2Bs. Not many of our geriatric patients want to work out to that muscle burn. So traditional exercise, you got to go through type 1s before you start working majority of those type 2s. The beauty of NMES, it's non-discriminatory. It gets them all. It goes to the largest motor neuron, and your largest motor neuron is the king of the jungle. It innervates your 1s, your 2As, your 2Bs. It gets them all. And it gets them all day one. First time you see motor, if you don't see this motor contraction, you're not doing NMES. It is sensory stim. But when you see motor, you are getting true NMES. And that's why I'm showing it to you. And one more thing I'm going to say before I let the doc take over is it's a perturbation. I'm already seeing some looks like this. I don't know what a perturbation is, Russ. I'm giving
I think that the looks are that it's Matt's up, but go ahead. Go ahead.
Matt's up. It's probably, thank God Matt's up. Matt's
Well,
up.
we don't want to cut him short.
We got
He's
it.
got
You still
he's
got
got the technical side.
All right, so good.
Go ahead,
So
perturbation.
if this bag was empty, and I asked Brooke to lift this bag up from the floor, she lifts it up, puts it on the table, no problem. Piece of cake. Healthy young woman, she can lift this bag up, put it on the table. All right? The next time I tell Brooke to lift this bag, she doesn't know it, but I drop a 50-pound sack of potatoes in this bag. Brooke's still young. She lifts it, but it throws her off a little bit because she wasn't anticipating the 50-pound sack of potatoes. But she gets it up on this table, and then she puts it back down. I tell Brooke to do that 10 more times. Every time, Brooke gets better. She uses her glutes. She uses her thighs. She bends her knees. She pulls the bag in close. She pivots. She puts the bag on the table. Every time she gets a little bit better. She motor learns. She motor plans. Okay? The 11th time I tell Brooke to lift up this bag, I remove the sack of potatoes out of it. Does Brooke overshoot the table or undershoot the table when she goes to lift? Come on, y'all. Give me this for overshoot. Give me this for under. Yeah, over. She overshoots the table, right? Because the sack of potatoes, the 50 pounds, was the perturbation. The electrical stim is the perturbation. It's pulling the hyolaryngeal complex, addressing that impairment, facilitating that, and creating a stretching to when they swallow with this on, work timing and initiation, they will speed up airway closure times. So with that to do, I will turn this over to Dr. Dumican to go ahead and show you how he's using the TIMS MVP system to validate that. God bless y'all.
Neck roll, Russ. Neck roll.
I thought I was calm. That's a
You
calm
were,
baby.
yeah, you were, I don't know. I said neck roll.
Well, while I get this set up, I just want to say me and Brooke have been asked to do a lot of things in this webinar so far. We've been pulled down by ropes and we've picked up sacks
Yeah,
of potatoes.
picking up bags. True.
We're picking up bags. We're doing a lot of things that I didn't think was going to
Yeah.
be a part of this. That's all I want to say. So I just want to say thanks for Tim's and for everyone having us here. I just want to make sure, can everyone see? I have the Tim's MVP system up right now, and y'all can see a swallow study perfectly fine right now, right? All right, perfect. Still seeing it okay? All right, beautiful. So hard to follow up a presentation from both Rick and Russ, but I'm Dr. Matt Dumican, and the big thing I want you to take away from this, right, is I'm a clinician first and foremost, and so a big thing of everything I'm constantly trying to do is how can we make things efficient and easy enough on clinicians, because we keep getting asked to do more and more with less and less time and resources. And so the biggest thing I want to try and do is walk you through as quickly as I can how to translate kinematics or movements, distances, and timings into quick, measurable items that you can track during assessment and after treatment. Whether that's from something like NMES and the patient I used to demonstrate some of these measurements underwent and had NMES as their primary modality after having a stroke. And so I really want you to, whether it's NMES or a Mendelson or an effortful swallow or whatever exercise paradigm and program you're using to try and enact change in swallow function, how can you track that, right? Because there's so many things you could possibly do to measure and score the swallowing physiology of a patient, right? And there's a ton of amazing resources and validated ways of measuring ordinal scales and other timings and whether things are absent or not, like swallow initiation, whether something is complete or incomplete, like laryngeal vestibule closure. And that's great. And what I want to do is bring some more objective, quantifiable measurements in place that you can do from the beginning of the first patient swallow study and track through until after treatment at their final swallow study before you upgrade their diet or discharge them from therapy or whatever it is, so that you have quantifiable numbers that you can track and measure over time. Now, to do this, I've chosen 3 specific measurements, okay? One is a timing measurement, and all of these, Russ and Rick have already referred to throughout, but I'll just recap real fast, and then I'll tell you why I chose these to kind of look at. First one we're going to look at, laryngeal vestibule closure timing, or how quickly it takes to close the airway. The second measurement we're going to look at is peak hyoid excursion, right? Russ spent a lot of time talking about why hyolaryngeal excursion, the movement of that hyolaryngeal complex is so important, moving it out of the way of an incoming bolus, but also enacting some kind of secondary and inferential movements like UES opening and stuff like that. So airway closure time, peak hyoid excursion, and there's other things you can measure, but we'll stick with peak hyoid because efficiency. And we'll also measure penetration aspiration, right, via the penetration aspiration scale, okay? And that's worked in there, and I want to show that, one, because I want to show change from treatment, right? And there's obviously a lot of things we could measure. But one of the things we're often concerned about as clinicians, a lot of things we want to change physiologically to prevent is something like penetration and aspiration, whatever the cause might be. And so what I want to do is I want to score that in a patient who had NMES pre and then post-treatment, so we can see if laryngeal vestibule closure got faster and if peak hyolaryngeal excursion got further. Do those physiological changes then change the airway protective response or effectiveness? Okay. And now the reason I chose time to laryngeal vestibule closure and peak hyoid excursion to measure there is, well, because this patient had NMES as their primary treatment. Now, for all the things that Russ talked about in terms of perturbation and contracting the suprahyoid muscles, that's the meat and potatoes of what NMES is. That's the second potato reference I've had already, and I'm surprised we've had so many. But that's the meat and potatoes, right? When you're doing NMES, and again, I'm focused there because that's the patient that we're going to look at pre and post treatment. But I mean, whether it's Mendelssohn or efferent swallow or whatever it is, whatever you're trying to measure, what NMES is trying to do is facilitate hyolaryngeal excursion and adding that perturbation into the mix of stretching open the laryngeal vestibule, which progressively over time, which is what you want in a therapy or exercise program or paradigm, is progressively over time, those things would facilitate better movement, move it out of the way of the bolus, and act in that perturbation to help get to the airway to close faster, right? So that's why I chose those measurements, is because if you're doing something like NMES or Mendelssohn or whatever you're including as treatment, if you're doing something like NMES, then the impairment that you're primarily targeting is hyolaryngeal excursion and laryngeal vestibule closure, right? And so if that's the treatment you're choosing, those are probably the impairments you're focusing on, right? That's the reason why a patient might be penetrating or aspirating. And so those are the things we want to measure. There's a lot of different ways to measure those things, and it could be subjectively. And I know that's how I was trained, and that's how I learned how to rate things. And it's, hyolaryngeal excursion, it's reduced. How do you know? How much, right? We have little tricks of the trade. We want to look at if it tucks up under the mandible or whatever we look at, but there are ways we can efficiently try to track these things quickly. Okay, and that's what I want to really get to the point of. Okay, so the first thing we're going to do is in the swallow study I have up, right, is we're going to look at a pre-treatment swallow study of a patient who had NMES, and then we'll compare the post-treatment swallow study. Okay, and we'll look at airway closure, peak hyoid excursion, and we'll look at did penetration or aspiration change. Okay. Now, because of time, and I knew time would be a thing, we're going to look at 4 swallows in this patient: 2 pre-treatment, 2 post-treatment. Okay. Now, when we do airway closure, when we time that, we're going to look at saliva swallows. And the reason I picked that is because sometimes it's hard to judge if the airway's closed or not when there's bolus stuff in it, okay? And so it's much clearer to look at pre and post. We just look at saliva swallows, and there's also some data out there that says NMES speeds up just saliva swallows too. So I think it's also a good way to show and track some of that change. And then we'll look at a mildly thick or a nectar thick bolus for the same patient, same size bolus, same consistency pre and post. So we have some comparable measurements that we're looking at, right? So the first thing we're going to look at is we want to look at laryngeal vestibule closure, or specifically time to laryngeal vestibule closure, right? And Russ had a great picture up there earlier, and I see some stuff in the chat and Q&A, and y'all can take care of it if you want. There was a great picture that kind of tracked what is the laryngeal vestibule, what are we looking at, and I'm just going to trace that super fast so you have an idea of exactly what we're looking at, right? And the laryngeal vestibule makes up everything of this kind of upper airway, from the petiole of the epiglottis to the peak of the arytenoids, and all that space in there where the vocal folds are, okay? So when we time laryngeal vestibule closure, that's what we're looking at to close. Okay, we're looking for all of that space in that airway to go away, right? Or what we call kind of being obliterated, okay? So I'm going to clear that annotation real fast. And here's what we want to do. We want to start timing laryngeal vestibule closure at the onset of that hyoid burst. And I'm sure a lot of us were trained where the onset of the hyoid burst marks the start of the pharyngeal phase of the swallow, right? And so that's where we're going to start timing how long it takes for that airway to close. Now, I want to make sure we have enough time for Q&A, and I'm typically very interactive with this stuff and stubbornly patient in Q&As to see if I can get comments, but I've kind of marked out where this hyoid burst is. And what I'm going to do is I'm going to track through frame by frame so you can see exactly where that hyoid burst is. Now, it's hard in real life, in the real world, because when people talk, when you move, when you open your jaw and you do stuff, the hyoid, it bounces around. The larynx moves up and down. And so what we're looking for is when we start timing it from as soon as that hyoid takes off and it's not coming back, right? As soon as that hyoid launches into orbit and it's not coming back down, okay? So what I want to do is I'm just going to track through, and you can kind of see there's some, even if I go back a little bit, this patient, while they're sitting under fluoro, there's a bunch of movement and a bunch of other stuff happening, and they're all kind of moving around. And so what I want to do is I want to find the frame where that hyoid really takes off, right? And so we're getting close as I track forward here, kind of going frame by frame. And you can see I have my little time down here in the right-hand corner. And that's what's going to be important when we look at how do I time laryngeal vestibule closure, right? How do I do that? It's pretty easy, especially on TIMS MVP, because it'll calculate it for you, and it's really, really nice. So what I want to look for is that hyoid to really take off. And at this frame, you can kind of see, what are you seeing here? Are you seeing some, I see the hyoid, it's posturing, it's kind of gesturing a little bit, right? At 8.6 seconds. That's our runtime there in the lower right-hand corner. That's how much time has elapsed. So you see that, and you're like, oh, did it take off? Has it gone yet? Let me show you the next frame. And that's what we're looking for, is this. See how it goes? It gets ready. It's like a sprinter that's going down in their stance, right? It's posturing, it's getting ready, and then on this next frame, whoosh, right, that hyoid takes off in that anterior superior direction. And after that, it's not coming back down, right? It gets ready and then takes off, okay? And so that's where we're going to start timing laryngeal vestibule closure from, all right? And so there's two ways to do this, right, traditionally. One is, well, I could write down 8.633 as my time and track through until I've hit complete closure and then do some quick math. That is one way to do it. Or you'll see this little clock down here in the right-hand corner right next to the time. If I hit that clock, it changes that timing to zeros and it gives me a delta. And delta means difference two. That's used in a lot of like time-based series, and they use that in like racing and stuff like that too, okay? So what I'm going to do now is I'm going to start tracking forward. And that clock down there, that delta, is going to start telling me how much time in fractions of seconds or milliseconds has elapsed until laryngeal vestibule closure is complete. All right. Now remember, again, we're looking for all of this space in this laryngeal vestibule to be closed. And that's what we're looking for. Okay. So what I'm going to do is I'm going to start tracking forward. And what we're looking for, again, you can start to see those are arytenoids. They're starting to approximate. The epiglottis is starting to invert on that frame. If you kind of watch your eyes right here, you can kind of see the epiglottis go boop, right? That airway is starting to close. See this space right here? It's starting to shrink. It's getting smaller and smaller. And we're tracking and tracking, and we're almost closed. But there's still a little bit of space in this laryngeal vestibule right here. There's still a little bit of white in that screen. And when we go to the next frame, it's gone. That right there is the arytenoids are up against the underside of the epiglottis, even though the epiglottis isn't all the way inverted yet. And well, this is a pre-video, so stay tuned. The arytenoids are all the way up against the epiglottic petiole, and all of that laryngeal vestibule space is gone. So I would say right there, laryngeal vestibule closure is done, complete, no airspace left. And that took how long? That took 0.233 seconds, 233 milliseconds. Okay, if we look at our normative typical data, that's even on a saliva swallow, that's longer than we want it to be. Right? We want airway closure to happen generally less than 200 milliseconds. Okay, or right around 200 milliseconds. All right, so you have laryngeal vestibule closure. That's it. That's all it is. Right? It's not some mysterious thing that is hyper complex. It's there's airspace, and now there isn't. And that's it. And that's what we're looking for. And that's how we can time something like that in a system like this. It does it for us instead of having to calculate these things on our own. Okay. So we have laryngeal vestibule closure done. And so you can either write that down yourself, but there's also a really cool kind of notes box down here where if you need to track things or you need to keep track of hyoid excursion or other timings or other things you're looking for, you can kind of pop those notes in there and keep track of all the stuff that you have to. So pre-treatment LVC was 0.233 seconds, 233 milliseconds. Now you can also track it with frames if you really want to. That's totally acceptable also, but I feel like time might just be a little bit easier in a lot of instances, especially if you're pressed for time. So what I'm going to do is I'm just going to revert back to our recorded time here. And I'm going to just really quickly, I'm going to go through because we want to get our next measurement. Right, we've got laryngeal vestibule closure timing on this saliva swallow, which is looking kind of outside of our normal, typical range. And I'm going to fast forward a little bit. You're not missing anything, I promise. I've got a bolus swallow coming up right about here. You can see that bolus in the oral cavity is starting to come down the base of the tongue. And what we're going to do next is we're going to get our peak hyoid excursion. Okay. So what I'm going to do is I'm going to track through and fast forward just a little bit because again, I know I'm pressed for time a little bit, but to get peak hyoid excursion, right? The maximum amount that hyoid is moving in a pre-treatment individual. Well, what we need to do is we need to find the frame where the hyoid is at its peak. You know, that is actually pretty easy to do. And what we're going to look for is we're going to look for that hyolaryngeal excursion at the height of that swallow. We're going to look for when that hyoid hits its peak and it's not moving anymore, right? It's plateaued. It's kind of what we call it. And we need to be a little bit careful because the hyoid is moving, but so is a lot of other stuff around it. The patient might be moving. They might be kind of tucking their head. Their mandible might be coming down. So we need to make sure we have the frame where the hyoid is done moving as best as we can. I think something else to remember when you're doing these measurements too is it's okay to be off by a frame or two or a few fractions of a second from a colleague who might be measuring the same thing. All right. And what I want you to get out of this more than anything is as long as you are measuring the same thing the same way in the same patient, that's ultimately what's important. Okay. So what we want to do is we want to track through as best we can and find the peak hyoid position, right? And now you can see that hyoid is taking off. It's starting to make that anterior movement. And we want to try and find, when is it at its peak, still moving, still coming up? I think right around here, and this is why I mentioned be careful of other movement, right? Because as this hyoid is starting to hit its peak, what is the patient starting to do, right? And I'm just, right, it's headbanger's ball a little bit, right? They're coming forward as you go to this frame and that frame and trying to see right around 29.5, 29 and a half seconds, hyoid's at its peak, right? The pharyngeal phase of the swallow is at the height of the swallow, right? And so what we need to do now is we got to measure it. We got to measure how much peak excursion there is so that when we do NMES or an effortful swallow or a Mendelssohn in treatment, we got to track what was their hyoid excursion now. So that post-treatment we can track, did it improve? And if it did improve and penetration and aspiration or whatever else you're measuring got better, we've got a physiological rationale as to why they got better. It's not just, oh, they're not aspirating anymore. It's what is the reason? What is the physiology? Okay. Now, there's a lot of ways to measure hyoid movement. Okay. Some of you may or may not be familiar with the concept of scaling hyoid movement. Okay. Something that we know, something that's the most appropriate thing to do is we can't just willy-nilly measure distances in an image and assume that it's accurate or representative of true movement, right? Because when we're measuring things in an image, we're measuring pixels, right? 'Cause that's what an image is made of, and that's what a swallow study is. It's an X-ray movie. It's a series of images that are tied together, right? And so there's a couple ways we can measure this. For a long time, the kind of best practice was, well, we take a physical object like a penny or a pence, depending on where you're from, something that's a known size, and we calibrate hyoid movement to something in millimeters. And that's still done in some areas of GI work, and that's great, and it's maybe still being done wherever you are doing swallow studies, and that's also fine. That is a way to do it. But we're starting to learn the best, and maybe best practice way to do it is actually normalize hyoid movement to each individual patient themselves, right? Normalize how much hyoid movement there is to internal anatomy for the patient. And the reason we do that is because if we use something like a penny, if it's maybe too close, or if the image is blown up or distorted, it messes with what you're actually measuring in terms of real distance. Another reason we have to normalize this stuff, right, is because the height, size of someone's laryngopharynx and larynx and hyoid and suprahyoid musculature, all this stuff it's different, right? A huge NFL lineman is going to have a huge size of their system, right? Their larynx, their laryngeal structures, their laryngeal vestibule space, it's going to be a lot bigger than mine, okay? And so we have to normalize these sizes, these measurements to each person, and then reflect it that way, right? So we're going to actually look at hyoid peak excursion as a percentage of a person's spine, because their cervical spine it's a known distance, right? We can measure someone's spine in fluoro, right? In this image, we're going to do it right now. And then we can reflect hyoid movement as a percentage of that, right? Of that known distance. And so what we have to do is we have to find, well, first we're going to find the C-spine, right? I picked this patient in particular because it's pretty clear, right? And there's a lot I've filtered through, and it's like, this patient has a pretty clear spine. And so the best practice way to do it is to draw a line, is to measure from the bottom corner of their second vertebrae to the bottom corner of their fourth vertebrae. And so that's what we're going to do. And so if you want to kind of count along with me, I'm zoomed out a lot here so you can kind of see. You can see base of skull right here if you look at this image, right? And if we kind of count down, we have our kind of first vertebrae here, second vertebrae, third, and fourth, right? So what we're going to do is we're going to draw a line from the corner of our second vertebrae down to the corner of our fourth vertebrae. And I'm gonna, because it's late East Coast time and my eyes are getting sleepy and tired and weak staring at this image, I'm gonna zoom in a little bit, just so for the sake of being able to see and so you can see it better too, right? So what we're gonna do is we're gonna take our crosshairs a little bit, and here's what you're gonna do. You come over to the right-hand side, you can see I've been messing with these annotation tools a little bit. And so if you need to draw a line, like measuring peak hyoid excursion, or you're measuring the C-spine, or if you need a freehand tool because maybe you want to kind of trace the C-spine so you know exactly where you're measuring from, you can do that too. So if you're going to do this anatomical scaling so you can measure peak hyoid excursion, we're going to come over to our sidebar over here, and we're going to find just our line tool, and we're going to click on our line tool. Okay. And what we're going to do is we're going to go up to this handy dandy ruler, because what do you need a ruler for? You got to measure stuff. So that's what we want, right? We want to measure how long it is in pixels from vertebrae to vertebrae. So that's what we're going to do. We're going to find the little corner of C2 here, and we're going to, as close as we can, pick the most bottom corner. Okay. And again, I'm going to stress the biggest thing you could do is measure it the same way for you in a patient every time. Okay, that's how we build and how you build consistency. And so I click, I'm in my right hand, my bottom front corner of the second vertebrae, and I'm just going to draw this line down and approximate it as best I can to the bottom of the second vertebrae. And I've got a line, and I've got a measurement in pixels. And if you come up to the right-hand corner, it records that measurement for you, right? And so I'm going to do this so I can keep track of this stuff. I'm going to just name this real fast. And that's my C2, C4, not sum, but spine scalar, okay? And so we have that, right? We have a normalized number. That's how long in pixels it is from C2 to C4. And so the next thing we got to do as best we can is draw a line from the bottom of C4 up to the corner of our hyoid bone. And typically the spot we use to measure peak hyoid excursion is the bottom front corner of the hyoid bone, just like bottom front corner of the spine. Now, why do you think we do that, right? Why not the top? Why not the back corner or the back superior side? And I think the biggest reason is the bottom corner is going to be the most visible for you. If that hyoid tucks up under the mandible and you're measuring from the top corner, good luck, right? Good luck distinguishing the hyoid from the mandible, right? Two bones apart from one another, okay? So we have our spine scalar, right? We have our peak hyoid excursion in pixels. But now it's like, what do I do with this? I've got the length of a spine in pixels on an image. I've got the distance at the top of the swallow from the spine. What do I do with this, right? Well, in order to scale it for each person, we have to divide and get a percentage. And the percentage we're looking at is peak hyoid excursion as a percentage of C-spine length. right? So what we're doing is we're getting a known length of a spine, and we're saying the hyoid moved to its peak point of excursion X percentage of the length of this person's spine. That's how we're normalizing this measure. And now there's a couple of things you can do, but I've got my calculator, and all you really got to do is type in peak hyoid excursion, which is 171, and you divide it by 131. And what you get is 1.305, or if we're kind and we round up, 1.31. And so what that really means is our peak hyoid excursion is 1.34 times the length of our C2, C4 spine. And another way to think about that is the hyoid moved, the peak hyoid excursion, the length of that is 130, that's 1,000, but 134% of the spinal length, right? And I realize me talking through that, there's a lot of steps and it seems very long to do and to implement, but you're just drawing a line down the spine and then drawing that line to the peak of the hyoid excursion. And when I go very quickly through the rest of the post-treatment swallow study, you'll see line, line. And that's really all it is. And it takes practice to get used to doing it, but this is all it is. It's not a mystery. You know, you read this stuff in papers or whatever, and it's, how do you do it? This is how, right? I'm going to clear this stuff and I'll do it again. You draw a line, you draw a line. That's it. That's all it takes. It's the only thing that takes time is the practice to get comfortable with it, but that's all we're doing. We're drawing lines and doing quick division. And now you know peak hyoid excursion is 134% of this line, spine length. And you can do that within each person you get. And this is a cakewalk. It's a breeze to do that and a really easy measurement that you can do. Okay. So last thing I'm going to do real quick, because I know button up against Q&A time, is we know what the hyoid excursion is, right? We know what laryngeal vestibule closure timing was. Did this person penetrate or aspirate, right? And you probably saw as I was tracking through, you saw it on the pause frame where I was, there's something going on. There's some laryngeal impairment, there's some airway protective response issue happening here, right? So if I track through, right, swallows initiated, we got a lot of bolus in the pharynx, airway starting to close. We're starting to see that bolus pupil come up, tip in, and what do you see, right? If we look, right, oh, we're already throwing fingers up. Russ is already taking a gander at what we think it's going to be, right? We've got at least penetration of material into the laryngeal vestibule, right? But for the sake of argument, let's track through and see, does it evolve into anything worse? Okay. So track through the swallow. Now, is anything contacting the vocal folds? If we think about where the vocal folds are, it's that last line of defense, that thick bar that goes across the trachea. Nothing at the vocal folds yet. Okay. Tracking through. Okay, not evolving, not changing. But now the contrast is a little light in the airway. We don't know if it's evolving into aspiration or not. Let's take a look. There's a secondary swallow that comes. And we can still see this contrast material that's still in the laryngeal vestibule, right? And so Russ already threw up a guess, but if contrast material gets into the laryngeal vestibule and stays there, it's not ejected, but it doesn't evolve, what do we score that as? It's a PAS of 3. And so what I like too is if you come up to this top row on this MVP system and you check out score, not only does it give you a bunch of scorecards, like I'm saying, if you were scoring MBS IMP or you're using some other residue scale or using digest or doing fees, it lets you do that. Okay. But what it also does is it can help you track based on bolus, right? What was the PAS score? What was the penetration and aspiration? And it even gives you on the dropdown, it gives you the definition based on the depth of airway invasion and what the response was. And so we know for this patient, we just watched PAS of 3, got into the vestibule, and we know it wasn't ejected. It's still there. Look, if you look at the screen, still there. Didn't go anywhere. And I tell you, you could track through the rest of this frame. They don't cough, they don't throw clear, they don't do anything. So nectar thick bolus, PAS of 3. Is a PAS of 3, should we expect material to get into the airway when someone swallows? And the answer is no. Okay. Now, again, this is just one swallow of this patient, but we know already that's atypical. Right? We don't expect that to happen. So I'm going to do real fast up against it. Y'all, let's do a post real fast. I'm going to try not to go long or go over, but let's do post treatment. Let's do a post treatment video super fast. So let's
how would you do it now, Matt? Now that you know what you're doing, we kind of know what you're going to do. If we were over your shoulder, how would you go about measuring?
All right, so here's the first thing I would do, right? First thing I would do is I like looking at time instead of frames. You can do it in frames. There's a lot of literature that says maybe frames are better, but there's also plenty of literature that says you can convert time in frames interchangeably if you know the frame rate is recorded at. So I think it's whatever your personal preference, just do it the same way every time. If you're going to do a pre-treatment in seconds and milliseconds, don't do the post-treatment in frames because it's not going to be, you're not going to have representation, or it's going to be harder for you to do. So I have my time set to 0, so we're at the beginning here. What I'm going to do is I'm going to track through super fast and try to find our saliva swallow. And this is a really great example of, look at this, look at what this hyoid does while they're just sitting there, right? They're maybe moving their tongue or trying to, maybe some lingual pumping to try and get a saliva swallow going. It's bouncing up and down and all around. But we want to try and find that, that point of no return where that hyoid takes off. And there's no coming back down. There's no going back. And so I'm going to track through and I see some posturing, right? So they're not swallowing, but you see that tongue base moving around. They're starting to get ready. And I see this kind of, again, it's the sprinter getting down into the stance. They're posturing, getting ready, and then watch the next frame. It just takes off, right? That's what you're looking for. And I know it is hard if you haven't, maybe don't time learn vestibule closure timing or whatever it is. But again, look for that. It takes off and it's not coming back, right? Look, it's not, the swallow's on, right? It's not coming back down. And again, the important thing to remember, I think, is time it the same way for you every time. You can disagree within milliseconds, within a frame or two, and that's okay. There are disagreements all the time. It's all about how are you measuring it for your patients every single time. Be consistent. And so I think for me, that takeoff is where I'm going to start timing from. Right? I think that's the point of no return. And so I'm going to turn on timing mode. Right? And so what I'm going to do is I'm going to track through and look for all of this white space in that vestibule to go away. I would say there's still a little bit here. It's not fully closed. I know the arytenoids are approximating the epiglottis, but that full vestibule squeeze, I think it's important to remember too, like when you swallow and the airway closes, it doesn't just butt up against stuff, it squeezes. Right? The aryepiglottic folds collapse and those arytenoids come up and it squeezes. And so I'm still seeing some some white, some open space in there. If I go one frame, I want you to look right here. Watch this white line of space turn to gray, just like that. Open, still white space, closed, grayed out. I see no space anymore. And if we come back and we look, again, the saliva swallow, post-treatment, we come down and look at our timing delta, our difference, right? What was pre-treatment? Their laryngeal vestibule closure timing was
2:33.
2:33. And post-treatment, again, saliva swallow, okay? It is now what? 0.2 flat, right? Right. So we sped up by 0.03, right? And now we're looking at a saliva swallow. It is pre-post treatment, but if we know anything with airway closure timing or any other timing we look at in swallowing, timing matters. Fractions, milliseconds can matter and make the difference between airway invasion or not, right? Aspiration versus penetration or not. And so I think the fact that we can demonstrate same person, pre-treatment, post-treatment, sped up saliva swallow. And if I had time, I totally would have gone back and we could have looked at what does timing look like in that penetration aspiration one that we had, and what is the next one coming up, the bolus swallow we're looking at. So laryngeal vestibule closure timing, faster. So I'm going to revert to our recording here and I'm going to just fast forward. Let's get to our bolus swallow, yeah? And so same patient, same consistency, same volume. Now they're going to swallow. Already, swallows initiated, and what do you see as a difference? What did the first pre-treatment swallow look like? I mean, the whole bolus is in the pharynx, severe pharyngeal delay. All right, I know maybe you weren't counting out, it was 4 seconds of dwell time of that bolus in the pharynx. And now that bolus is entering the pharynx as the pharyngeal phase of swallowing is being triggered. I mean, that's a huge decrease in time for pharyngeal swallow. And so what we need to do is we're going to do our peak hyoid excursion. So we need to track through, we got to find where is our peak hyoid position, okay? But without it being too head moving forward, what else is moving around, where's the plateau? And I feel like we're right about here, right? We track through, it's still moving, still reaching its peak. We get to 10.9. If we go a little bit further, there's no extra movement, right? I mean, it's just kind of, it's plateaued, right? It's just kind of there. And so all we got to do, and again, I'm going to brighten up and zoom in. We need to measure our C-spine length, and don't forget to put our ruler on. From corner to corner, and then corner to hyoid. So you can see, again, there's a difference in what we measured for C-spine length in pre-treatment, but that's why we have to normalize, right? Because pixels change, resolution can change, the position of the patient might have an effect, the angle might have an effect, so we have to normalize every single swallow that we're measuring. You have to, that's part of it. So our C-spine length, what we measured was 128. I'll even type it in here. C2, C4, and then our peak hyoid. And now we got to do some quick math, right? Because we got to represent this as a percentage of our spinal length. All right, who remembers what it was before? What did we have? Actually, we have our notes anymore.
171.
171, and it was 171.
Was it 130?
Divided by, I think it was 131.
Yeah.
So we had 131%. Okay, 1.31, right? That's units of spinal length. So let's do the quick math on when we measure this now, post-treatment, 1.36. Okay, so we had, if we're kind and round up, okay, that's a 5% change in distance, right, of spinal scaled distance pre-treatment and post-treatment, right? And I mean, is there guidance on how much percentage matters? I don't know, but it's an improvement. I mean, 5%. That's the difference between an A and an A minus. That's the difference between an A minus and a B plus. I mean, that's helping the GPA a little bit. Does it matter? Like, does it matter? If we look at the same bolus, same person, pre-treatment, where's the penetration and aspiration? No airway invasion, no contrast material entering into the airway, right? If we take our score, we look at our PAS again, that's a 1. Same person, same bolus, same volume, pre-treatment, post-treatment. Penetration with material remaining in the vestibule to a typical swallow, right? Typical normal swallow. So that's what it takes. And you can see on the post-treatment ones, I was talking and we were talking about things, but it's quick and it's not a mystery. It's really, it's drawn lines. There's just no one, what's the protocol and what's your protocol going to be? Just make sure you're measuring it the way you need to measure it, the same way every time.
Very nice. Brooke, do we want to address some of the top questions now? So
Yeah.
what do we need to do on your end?
Yeah, so if anyone needs to log off just because we're a little bit over time, feel free to do so. But just reminders for ASHA CEUs, we just need you to fill out the survey. The link is in the chat. It'll be emailed out via Zoom as well. But if you forget or you didn't sign up to opt in, you can access the link via our website. And then if you want a certificate of completion, like I said, feel free to email me at tims-univ@tims.com. And then that's pretty much it for ASHA stuff. We'll keep the survey open until next Thursday. And the replay for this will be available. It should be up no later than tomorrow afternoon. I'll try to get it up tonight. Just depends on how fast Zoom processes it. So with that, we'll pop over to some Q&A. And like I said, feel free to stay on if you all have time. There's some great questions. So I'm going to kind of go through these real quick. So one of the questions was about quantitative measures. So Matt, I'm assuming this one's probably for you. The question is, other than the timing of laryngeal closure and measuring spine to hyoid excursion for peak hyoid excursion, what other objective measures do you find most useful to show quantifiable improvements with NMES?
That's a great question. Way to kick it off. Yeah, I love that.
And
yeah,
I
so
would say to you, Matt, I mean, not only from NMES, but any treatment modality, right? Or anything you're doing for what all do you look for, to evaluate, quantify?
Yeah, I mean, and I think it's, I mean, for both time and for just the content of the topic, I mean, there's so much, right? There's just so much that you can quantifiably measure, both timing wise and from a what we call a pixel base, right? Measuring distances or space, right? Spatial or volume based things that are in a swallow study. I think, yeah, there's so much, and the current literature is kind of what we think we know, right? Is the one thing we without a doubt should be measuring is the laryngeal vestibule closure. I mean, I think time and again we see in the data and clinically and anecdotally, the slower the laryngeal vestibule closes, the more likely there is penetration and aspiration to happen. I think, again, second to that, this can be debated up and down, and probably will be forever, is how important hyoid movement is. Russ alluded to that kind of earlier, is Does the hyoid matter? I don't know. It sure attaches to a lot of things and serves as an attachment point, origination point for a lot of things. And it's also, it's a component of laryngeal vestibule closure, alongside tongue-based retraction and a couple other things. So I think those two are probably the primary movers. I do think swallow reaction time, right? How long it takes to initiate a swallow is a pretty important quantifiable timing measure to gather. Because it's not always where the bolus is when you swallow, it's how long it's there for, right? It's dwell time. If you have a whole cup sip of water sitting out in the vallecula and the aryepiglottic folds and the piriforms, that's not great. But I think if you're tracking things, one of the best things you can do from a pixel-based standpoint is to measure vallecular and piriform sinus residue. Again, you're not treating residue, you're treating the impairment that is causing the residue. But I think it's a great way to track, hey, the effortful swallows I've been having my patient do have reduced this residue. And you can do it the same way, you just normalize it to the spine. And the math is a little different, but once you know it, it's easy. It's all anatomically defined. You just circle the contrast you see in the piriforms or the vallecula, so I think that could be a nice quantifiable way to show, hey, pre-treatment, X amount in the vallecula, the piriforms, and then post-treatment, look at how much this residue cleared up, or, look at how well. I think another one could be pharyngeal constriction. I think a lot of things that we measure in terms of pharyngeal constriction are kind of ordinal and subjective. Pharyngeal stripping wave and what pharyngeal constriction looks like, and is it reduced, is it abnormal? You can measure that, right? You can scale it to the spine, and then you just draw around the residue and you measure it in pixels. And so I think that's another thing that you could look at, because that's a component of whether someone's going to have residue, and is tied to laryngeal excursion also. So I think, maybe swallow reaction time, the initiation, and then residue and or pharyngeal constriction pre-post treatment, I think could be really great additions that are efficient and fairly easy to.
Things we're wanting to look for, right? Those are things we've been we think it's diminished, or we think the delay is X, those are things we could quantify.
Yeah, no, that's a great point, Rick, because that's something that we automatically judge, right? Mm-hmm. When we're looking at swallows, so we look at, is the pharyngeal phase delayed or not?
Yep.
And you can time that.
Yeah, right.
Yeah, and you can say, oh, it is or it isn't. And there's normative data out there to say how long it should take depending on the bolus and stuff like that. So it's the timing's the same way. It's different what you're looking at, but it's the same thing. You just track through.
That patient was the stroke patient, right? The one.
Yeah, post-stroke.
Do you remember what was the time post-onset? That was one of the other questions.
Ooh, I know it's from a larger data set. So I think everyone was still in the post-acute phase. I think those must have been within 2 or 3 months, I think.
I think.
And they had NMES for, I think the treatment period was 4 weeks or about a month. Which in reality is probably 20 days, 20 days. Without weekends. So, and again, I picked that one because, it had the clearest image, right? It had the clearest C-spine. I wanted everyone to be able to see this stuff and see, when it's not messy, to know what we're talking about. But there's a lot of data and, in that post-stroke population of how well something like NMES as a protocol, how helpful and how much it.
You want to cover that last question, Brooke, or I can ask it too, I think.
Yeah.
Goal purposes, do you think there is a peak percentage? Are we getting there yet where you could set a goal where, the way I look at it, it's still coming from the you want to show improvement based on the other physiology of the swallow, as opposed to saying we did a pre-exam and say that's that's outside of our norms necessarily. I don't know if you have an idea or a view of what would be your goal for that.
Yeah, I know whenever I talk about data and change from pre-post or whatever, my brain doesn't always think this way, but Russ's does, and I always appreciate this, is he thinks in percentage change from pre to post, right? And this, and I appreciate that because that's not always where my brain goes to, and I think the hard part is we have a lot of normative data on what peak hyoid excursion looks like, because there's a ton of amazing researchers doing that heavy legwork. What we don't have yet is there a percentage change we should expect from X treatment?
Right.
I don't think we don't have
Know that yet.
That data yet. I don't think I'm comfortable saying that, but I think if you're trying to say, could I set a goal and I want X percentage of hyoid excursion? I don't, we're not there yet.
I would agree with you. It's still going to come down to that patient. And I don't know that I could set a goal to eliminate penetration aspiration. I think we'll be surprised at how little bit of change can make a big difference. And it's not expecting, this high level of a goal. So I don't know if we're there yet. So hopefully that answers that question as well.
But it's such a good question too, because it opens up so many other doors of, we know what typical hyoid excursion is supposed to be as a percentage of that C2, C4, that scale measurement. We kind of know what it looks like in a bunch of different boluses and viscosities. But what I think we don't know is when that's reduced, where do we need to get, and there's penetration and aspiration or whatever as a result of it. Do we need to get it back? Or is it possible to get it back into that typical normative range? And does that matter?
And does that matter to the other physiology we're looking to change? I think that's something we'll start teasing out, whether it's great we got it, but in some other patients we didn't get it and they also improved. So I think that's the importance of the complexity of the swallow and how many things. I think from our perspective, treating the swallow with effortful swallows, I think is the best therapy because it's incorporating all of these things that we think we might want to measure. I don't know how to tease out one or the other. I don't know how to tease out better hyoid movement without them working on some challenge of the swallow. I don't know if you could just sit there and do tongue pumps, moving the hyoid, if that's going to get you the elevation you want. Certainly not as much as a swallow. So it's kind of one of those things we'll start to see as we have great capabilities of Thames Medical and the MVP. That's what I'm glad we had the opportunity to share all this, Brooke, and thanks for coordinating it.
Yeah.
Thank you all for your expertise and being here. I was dying laughing, listening to Russ, and learned a lot from Matt and Rick. And I put in the chat, people that are looking for normative data and kinematic analysis. I put in some resources from Dr. Steele. I know Matt was using the scalar C2 to C4, which is her work.
Yep.
Super easy to do in Tim's. The other things that he was mentioning, bolus percentages and things like that. We have tons of demo videos on our YouTube channel to show you how to do that. And after one of our previous webinars, we did update those tools to make them even more accurate and easier to measure bolus percentages, not with the freehand. So it's super, super fast. So be sure and check that out or reach out to me via email if you have questions. And I'll put in one more plug. Monday, Jonathan Waller is hosting a webinar through Dysphagia Cafe with Jessica Greger, and she's going to be going over the PES and talking about distension and how to measure that. So if you're interested in more kinematic and timing analysis and things like that, that's a great webinar to tune into, and it's free as well. So I just want to thank you all for being here, and thank you, Rick, Russ, and Matt, for your expertise and time. And with
thanks,
that,
Matt, for sure.
Yeah. Thanks y'all so much for being. I really appreciate it. Yeah.
All right, we went a little bit past, but I think it was very content full. So I think everybody knows how to reach out to us and to you. So let's all stay in touch and keep progressing our discipline as we go. We'll bring Russ with us.
Come along.
Cheers, y'all. God bless.
Right.
Take good
Cheers,
care.
everybody.
Thanks, everyone.
Everybody have a good night.
All right. Thanks, Brooke.